Welcome back to the EAU podcast on how to install intravesical therapy post-TURBT. In this episode, we are joined by Alexandra Masson-Lecomte, Professor of Urology at Hospital St. Louis in University Paris site in France, and Professor Fred Witjes, who is affiliated with the Urology Department. He specializes in oncological urology, cancer of the bladder, kidney, prostate, or testicle in Radboud University in the Netherlands. Join us as we embark on this informative journey.
Hi, everyone. It's my pleasure to participate with Professor Witjes to this podcast, EAU podcast dedicated to how to install intravesical instillations. So hi, Fred.
Hi, Alex.
Thanks for being here. So we have decided to address this issue using a clinical case with a patient I am following at the time being. So I will briefly introduce the case for the listeners. It's a rather young, 68 years old male. He had gross hematuria, as most of the patients diagnosed with bladder tumors. And so I did the cystoscopy and found 2 centimeters, unifocal tumor that was at the dome with negative cytology. The CT scan was normal, and I went for a TURBT. And the TURBT went well, but since it was at the dome, it was a little bit challenging. And I had a complete resection, but I had a small intraoperative perforation. It wasn't very big, but I could clearly see the fat at the dome during the TURBT. There was no complications afterwards, but just to be on the safe side, I left the catheter for 3 days. Usually I remove it after 2 days. And the first question that we had in the postoperative part for this patient was, can we or not do a single postoperative instillation? Because it was on the paper a very good indication, but I was a little bit worried because of the fats. What would you have done, and what is your point of view on that?
Well, Alex, I think if you look at the case, theoretically, it should have been a very good indication for a postoperative installation. It seems to be low risk, negative cytology, small tumor, solitary, first time for the tumor. So in that respect, I think an installation would have been state-of-the-art, as you do in low risk and in intermediate risk patients. However, if you already see the perforation during your TOR, and although you had the catheter for 3 days, I think you lost a little bit the window to do the single installation. You know that the guideline says that you should do it, let's say, within a day, within 24 hours, or the evening of the TOR or the next morning. There is a Dutch study which showed that even the second day might be useful, but now this is already 3 days. And I think you missed the window of the single installation. And like you, I probably wouldn't have done that.
I agree about the window. Imagine that the bladder catheter would have been removed earlier. If you see a little bit the fat during the TURBT, do you consider doing the installation if the patient is fine? Do you do a cystography in some cases to decide? Or if you see the fat, you just don't go for it?
Well, I think the last, because, obviously the additional value of one installation is there for the recurrence rate, but it's not life-saving. I wouldn't do a cystogram, I guess. If you've seen fat, there is a small perforation. Even if the cystogram is negative or, even if it's positive, it wouldn't change my decision. I would wait and start, maybe, depending on pathology, a course of installations or just follow up.
And what product are you using for the single postoperative installations?
Well, that's an interesting question. I know that the guideline advises mitomycin, at least chemotherapy. You might know that with Richard Sylvester, I have done a review, let's say maybe 15 years ago, on which drug is most effective. And basically all drugs are equally effective for one installation. My personal choice is epirubicin, which is accepted in the Netherlands because, again, my personal experience is that mitomycin is a very effective drug, but also has a little bit more side effects. And what you typically see, for example, after 3 months, if you do a cysto, you see calcifications in the bladder. They're not very harmful for the patients, but it's a bit more harmful than epirubicin. So we usually give, if we do the one installation, we usually give epirubicin.
Yeah, and you're right that in the guidelines, most centers use also mitomycin, but...
Yeah, I think so, yeah.
Okay, so for this patient, unfortunately, based on my poor quality TURBT with the perforation, he couldn't get the postoperative installation because I didn't do it. And I saw the patient in my clinics 2 weeks afterwards with the pathology results. And the tumor, although the cytology was negative before and looked rather like a low-grade tumor, was actually a TA high grade, so complete TURBT. So just to remind to everyone, this is a 68 years old male, so less than 70 years old, with a unique less than 3 centimeter TA high-grade tumor, no CIS. So let's ask you the question, if you know this classification by heart, Fred, what is the risk of these patients according to the EIU 21 classification for progression? What are the options for the installations in this setting of the kind of product?
Well, I think one thing, by the way, you says there is no CIS. Your cytology was negative. It's still high grade. So I assume you did biopsies or you didn't?
No, I didn't.
You're not 100% sure there is no CIS. So no, I think this guy is now an intermediate risk because, of course, he has one of the not very nice factors, namely high grade. To me, it's a very nasty factor, high grade, because those are the more aggressive ones. That means that you could have given the one installation. The fact that you haven't given that doesn't change your follow-up policy. And I think basically you should or give a course of installations with chemotherapy or a course of installation with BCG. I guess in this case, first episode, I would probably start with chemotherapy. And in that case, I would use mitomycin C. And BCG is, for me, a little bit more reserved for intermediate risk cases, which are a little bit higher risk or recurring because of more side effects of BCG. And obviously, sometimes there is a shortage of BCG. So in this case, I would probably go for mitomycin C.
Yeah, I guess you go for mitomycin because the risk of progression of these patients, even though he's a high grade, it's a TA, he has no other risk factor. So the risk of progression is rather low.
Yeah, it's below 5%. Yeah, sure.
With the calculator, I think it's like 6 or 6.4%. So since the risk is low, you obviously have the two options. Probably in my institution, we would go for BCG because it's a high grade. I know that there are a lot of institutions that consider that as soon as a tumor is a high grade, it has to be considered as a high risk and patients are treated with BCG. In the guidelines, you have both options, so both can be done. You can start with mitomycin. You're not going to put the patient at risk, and I completely agree. If the tumor comes back, then you can go for BCG.
Well, Alex, you know that with the IBCG, we divided the intermediate risk patients into, let's say, the very low risk intermediate ones and the higher risk intermediate ones, depending on recurrence rate, size, etc., etc. And this one is not very high risk. So I think, of course, you can do both, but mitomycin C is absolutely defendable. And my second remark, mitomycin C, if you give it well, it's a very effective drug. So I think what you see in reviews that there is not a very high risk in recurrence rate after mitomycin C or BCG, unless you, of course, give 3 years of BCG, what you probably would not do in this case.
And so if we go for mitomycin, how many installations do you do? Do you go for 6 or 8? Do you go for maintenance? How do you decide?
Well, I do what I was taught 30 years ago, which is 4 times weekly and then 5 times monthly. We give 9 installations. And again, what we saw in the review with Richard Sylvester is if you give it between half year and a year, that's sufficient and not too few. So more than a year is not useful and less than half a year is not sufficient. And, there are other schedules, just give chemotherapy and sort of maintenance schedule.
But so you give maintenance to every patient in your clinical practice?
I don't need maintenance for a longer time, but I mean really a course of installations with chemotherapy. So not 1 installation, but in my case, 9 installations.
Okay, so you do 9 induction installations and then you stop.
Yeah, it's an induction course. That's the right word. Yeah.
It's important for the listener to know that we don't know exactly the number of installations that has to be done, never less than 6, I guess, but then the exact number is unknown, and it's also a shared decision making with the patient depending on the appearance and the kind of tumor.
Absolutely.
Okay. When you go for installations, do you, this is a practical question, but do you do urine test or not? How do you manage when the urine test is positive, depending on symptoms, no symptoms? This is daily practice, but I mean, it's every week in my practice that the nurse comes with a urine culture asking me what we do. Do you have something very clear, some recommendations, although we have none, about how to handle that?
Yeah, well, those are really the practical things, Alex. They're very important. So in my department, the nurse does all the installations. Of course, when patients have complaints of a urinary tract infection, we don't give it, even if it's maybe chemical cystitis, we postpone for a week. If there is macroscopic hematuria, we're very careful. But if both are not there, even if the sediment, because we only do a sediment, not a culture, if the sediment shows some erythrocytes or some leukocytes, we still give the intravesical instillation, but we, of course, instruct the patients very well. So reasons not to do that for me are macroscopic hematuria and clinical signs of an infection.
Okay, so you don't perform urine culture systematically before the instillations?
No, we do that when we start instillation therapy. So during the first instillation, we take a culture, and the rest of the course, we don't do that.
Okay, well, it's a good way not to postpone the instillations for a patient who has no symptoms and
exactly
some bacteriuria that has no symptoms. Here, we don't have very clear recommendations. When I ask around me, all the centers are doing differently. In my center, some of the urologists are performing the culture and giving antibiotics if it's positive. I am not. I'm doing the same as you are doing if there are no symptoms. I think the main messages here are if you have a gross hematuria or if you have clear symptoms of urinary tract infection, do a culture and postpone the instillation.
Absolutely. And of course, do a culture when he has symptoms. That's obvious. Yes.
One last question is maybe I will start with what we did for this patient. For this patient, we chose BCG, which is a perfectly possible option. So we chose BCG with 1 year maintenance. When you go for BCG, I mean, I guess for the culture, this kind of stuff, it's going to be kind of the same. I guess it's the nurse who are doing it as well in your institution.
Yes.
How do you organize the cystoscopies? Do you do the cystoscopy the day of the BCG? Do you do it a week before? Sometimes it's getting a little bit, there's a little bit of mess between all the instillations at the beginning and the cystoscopies that have to be done. How do you manage that?
So basically, if you give the SWOG schedule, so 6 and then 3 after every next checkup. So we give 6 BCG installations. Then we wait 6 weeks. We do the cystoscopy, and if that's okay, we give the additional 3. And that, of course, the same at month 6 and month 12. And month 9, we don't do BCG. So I give it before the maintenance BCG installations.
So you do the cystoscopy just before, and if it's fine, you go for it.
Yeah.
Okay.
Yeah. Because if you do that, let's say 1 week after BCG, of course, it's very difficult to differentiate what you see from an infection or from maybe even CIS. So after around 6 weeks, I think most of the bladder abnormalities, mucosal abnormalities have healed.
I completely agree. I try to do the cystoscopy as close as possible as to the next instillation in order to have a proper healing of the bladder. What I want to insist on also is that sometimes there is a little bit of confusion about the first maintenance that has to be performed 3 months after the first instillation and not the last one. I see sometimes some schedules that are calculated based on the last induction instillation of BCG. It's very important for everyone who's listening to remind that it's 3 months from the first instillation. So as Fred said, it's only a six weeks interval between the last instillation of the induction and the first maintenance instillation, which is quite short.
Yeah, absolutely.
Usually what I try to do, since we do the cystoscopy just before the BCG, is to plan the cystoscopies and the BCGs for the first 6 months from the beginning, from the first instillation. Otherwise, I think it gets easily a little bit messy.
Now, Alex, do you do, let's say, the cystoscopy and BCG on the same day, or do you do 1 week in between?
No, usually I do the cystoscopy just the week before and the BCG just after.
Just there's, of course, a small chance that you damage something, and then BCG, of course, is...
Absolutely. It's just to be sure that there is no bleeding and that everything is fine. But I mean, if the cystoscopy goes well, there is no contraindication to doing the BCG afterward, particularly in a female patient, for example.
Yeah, agree.
Okay, so this patient, he went for the BCG. He had the induction course, and the induction course didn't go very well. He could not hold the product very well. After 30 minutes, he had some discomfort and he had to urinate. There was some burning in the 48 hours of the BCG. But I mean, each time he came back for the next instillation, he was fine. As you said, it's performed by the nurse. So I'm not always there when the instillation is performed. And I was not really aware that the patient had such a burning and discomfort. So he went for the 6th instillation. It went back to normal. And when he went back for his first maintenance, at the beginning of the maintenance, he had again a very, very strong local adverse event. So frequency with burning, with nicturia every hour. He was tired. So he had the first maintenance instillation. And the second one, and then I decided to stop because of very poor urinary comfort. And I saw the patient again 2 weeks after the instillation, and the symptoms were still exactly the same. So he had no fever, but very intense urinary discomfort and burning. What do you think of that? And how would you manage a situation like that?
Well, I think if you already have some problems with the induction course, I probably would have gone maybe for 1/3 dose. Although the URTC study doesn't see a lot of difference in toxicity for a full dose and 1/3 dose, my personal experience shows that 1/3 dose gives less side effects. And what I also do quite often is combine that with, it's a French study, by the way, with ofloxacin. So the evening of the instillation of BCG, 200 milligrams, and the morning after that, 200 milligrams. And it also gives a better tolerance for BCG. In your patients, you probably stop because he still has a lot of pains. And then you can go for or painkillers, anticholinergic drugs. And what you read, to be honest, I've never done that. You can give also corticosteroids inside the bladder. So you can then, like you inject in the bladder wall, you could inject at the side of the resection, because that's probably the side of the problems. You could inject some corticosteroids. I've never done that, but that's what you read everywhere.
Yeah, I think one also important thing, it's so obvious that you didn't mention it, but it's important to say it, that first thing to do is to check the urine culture to be sure that the patient doesn't have urinary tract infection. Obviously, I did that and the urine culture was negative. But this is a situation sometimes, I think it's underdiagnosed. You can have some BCGitis, some tuberculosis of the bladder after BCG and instillation. So first thing is that I should have been more worried after the first course of induction that the patient had such strong symptoms, and maybe I should have looked for something at that point. But this is how it went. So for the patient, the urine culture was negative, and we have in our department an infectiologist that is extremely interested in BCGitis and that is really telling us all day long that they are underdiagnosed. So since with anti-inflammatory drug and painkillers, the patient still had very strong symptoms, we tried both corticosteroids and anti-tuberculosis treatment, and we were very surprised to see that as soon as we started the treatment, the antibiotics, the patient got much better in just 10 days to 2 weeks. And there was really a clear on-off with the steroids and the treatment we started, the antibiotics. So the patient at the end was diagnosed with a local BCGitis, with a cystitis secondary to the product.
Which drug did you use, INH?
Well, it's there are 3 antibiotics.
Okay.
It's a
triple therapy.
Yeah, it's a therapy. Yeah. The same that we treated him as a urinary tuberculosis. We decided that he was contraindicated to BCG, and he had no symptoms outside of the bladder. But you can have, I think, the local effects can be quite intense. And if you have a patient with very strong local effects, you have no infections, and the effects are not resolving after you stop the instillations, you have to be worried that you are getting some symptoms that are related to the bacillus, and try an anti-tuberculosis treatment if the patient is not getting better.
So fortunately, like your patient, the clinical symptoms of BCG are usually not too bad. But you know that as well as I do. If you do cystoprostatectomy, and the guy who had BCG will find granulomas in the prostate in 9 out of 10 patients. So there's much more to be seen than we see it from a clinical point of view.
Yes, that's true. And so the message is that it's absolutely normal to have some local symptoms when you do some instillations, but they have to be short and they have to resolve.
Yeah.
If you have local symptoms that stay, first check for an infection. But if there is no infection and the local symptoms stay, then you have to try treating the patients with treatment against the
tuberculosis. Yeah, sure.
Because sometimes this is what happens, and frequently the patients are not treated and they go on with their symptoms for months. So in this patient, we stopped the treatment. He got corticosteroids and the antibiotics, and he got much better. But obviously, I stopped the BCG and started only following him with the cystoscopy. When he came for his second cystoscopy at 3 months, there was no papillary lesion, but the bladder was still very, very inflammatory. So negative cytology, inflammatory bladder, no papillary lesions. How do you manage those patients that have inflammatory lesions during the follow-up after BCG therapy?
Well, basically, if there are no symptoms, I would probably just follow that up. Like I said, you see also those kind of calcifications, and sometimes they look very nasty after mitomycin C. You know that we give a lot of hyperthermia. Also, hyperthermia gives a lot of, let's say, visual abnormalities in the bladder without patients having complaints. So I wouldn't treat what I see, but I would treat what the patient tells me. And of course, do a culture. And if that's okay, I would just follow him up. And if not, I would try to treat something symptomatically, treat the infection, or give again some painkillers or corticosteroids.
In my experience, we have a lot of patients that have inflammatory lesions during BCG treatment. Myself, I use two things. First, was there CIS at the beginning? If there was no CIS at the beginning on a TA high grade, chance that some CIS is appearing during the BCG treatment alone with no papillary lesion is rather low.
Yeah, it's very small.
So yeah, I'm not really worried. And second is the cytology. So if there is no CIS at the beginning and the cytology is negative, usually I do exactly as you do. I follow. One important point is to take pictures, because you never remember 3 months afterwards how was the inflammatory lesion and where it was. So you can describe it, but the best way to manage that is to take a picture. That way you know the next time how it has evolved. Otherwise, it's just like putting a finger in the air.
Yeah, no, you're totally right. We also make pictures of all cystoscopies.
All right. So, well, I think we've gone through my clinical case. Is there anything else you want to add about the tips and tricks of instillations?
No, I think we covered most of it. Be careful with the perforation and treat the patient and not what you see.
Absolutely, completely agree with this take-home message. So thank you very much.
Okay, Alex, nice. Thank you very much.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.